Hello everyone, it's so nice to be with you. In this symposium today, which I believe you will find most interesting, we will cover different aspects of ME CFS. I hope you will learn a lot and enjoy the day. My role is to give you a very brief history of ME. I will use this timeline, which I borrowed from a paper in clinical rheumatology. What makes it difficult to discuss the history is that the first diagnostic criteria were just published in 1988, so-called Holmes criteria. But I think it's very likely that ME CFS has been with us for a long time. Some think that Dr. Richard Manningham was describing ME in the 1760 paper, where he describes a disease with low-grade fever, lassitude, and cognitive dysfunction. George Miller Beard in the 1870s described a disease that he called neurasthenia, with fatigue that typically followed a short illness. Back to our timeline, we are now to the point where a disease with chronic fatigue was called atypical poliomyelitis. There was a polio epidemic in California, but a different outbreak happened at the Los Angeles County General Hospital in 1934. Close to 200 staff members were affected with a disease that led to chronic fatigue. 6 months later, 55% of the staff were still not back to work. Since that time, more than 70 epidemics have been described. And here is the list. I just briefly touch upon 3 of these epidemics. First, the Akureyri disease that was in Iceland. In 1948, we had an epidemic in the north of Iceland. It began just like a similar, or was similar to polio. It is of special interest since the epidemiology was well described and there is unusually long follow-up of the symptoms. The epidemic behaved like an infectious disease. Incubation time was 5 to 8 days, and the symptoms and signs in many ways were reminded us of a viral illness. The epidemic started in the town of Akureyri, where the largest circle is, but spread to other towns in the north of Iceland. Around 1,400 patients were affected. The epidemic was well described in the medical journals 1 and 2 years later. But then with a follow-up 7 to 10 months later and 6 years later, and it turned out that some patients were not recovering well and continued to have fatigue. Even 40 years later, some patients had not recovered, and 49 years later, it was found that depression was not the cause. The disease received the name Akureyri disease or Iceland disease. So how did the patients fare in general? 60% were able to live a nearly normal life, but 20% were sick their entire lives. We are now on our timeline where an outbreak happened at the Royal Free Hospital in London. It was in 1955 and close to 300 staff members were affected by the illness. In an editorial in Lancet in 1956, it was speculated whether this was a new clinical entity. A new name was proposed for the disease, benign myalgic encephalomyelitis. One of the leading investigators of the Akureyri disease wrote a letter to the editors of Lancet, where he argued that the disease was not in all aspects benign. He wrote this remarkable sentence: "I think this puzzling disease can hardly be adequately and permanently named until etiological and anatomical studies have better identified its nature." And 75 years later, we still have not progressed. 2 British medical doctors decided to revisit the Royal Free epidemic and also 15 other epidemics. They did not examine one patient, but came to the conclusion that this was a mass hysteria and proposed the name myalgia nervosa. Back to our timeline. We are now in 1984, when an epidemic of an illness broke out in Incline Village in Nevada, USA. 2 local doctors described the illness and published, among others, a follow-up of 258 patients 1.3 years later. 57% of the patients were still bedridden, shut in, or unable to work full-time. And now the disease was named chronic Epstein-Barr virus syndrome, as the virus was thought to be the cause of the illness. The Center of Disease Control in the USA started a working group a few years later, and the name chronic fatigue syndrome was proposed. And now, as we said in the beginning, and now for the first time, a working case definition was published, which we now call the Holmes criteria. Since that time, numerous criteria have been published. There is a slow progress in defining the illness, but we still lack diagnostic tools. So what do we know about specific pathogens leading to post-infectious fatigue? Well, numerous pathogens are known to be able to trigger the development of ME/CSF. And here you can see an incomplete list. This is an interesting study from Australia. 253 patients were followed prospectively after having had an infection with either Epstein-Barr, Q fever, or Ross River virus. 6 months later, 11% of the group met the diagnostic criteria of ME/CFS. And the type of infection did not matter. And here are a list of few pathogens that are well-known trigger to development of ME/CFS. Human herpes virus 6, dengue, West Nile virus, Ebola, and numerous others. Interesting, large outbreak of Giardia lamblia was in Norway. When those patients were followed, the prevalence of chronic fatigue was 26% at 10 years. I think that was remarkable. Another interesting study from the influenza epidemic in Norway in 2009 found there was a 2-fold increase in ME/CSF 3 years later in a patient that had influenza infection, but there was no increase in the vaccinated population. Quite interesting. And we have had coronavirus outbreaks before. Severe acute respiratory syndrome epidemic in 2008, and Middle East respiratory syndrome continues to be epidemic in some part of the world. Both viruses have been shown to trigger ME/CFS. So, does it come as a surprise that COVID-19 can trigger ME? Early on in the COVID-19 epidemic, Dr. Fauci speculated that long COVID likely is the same or very similar to ME/CFS. This will be discussed later in the symposium. And there has been a lot of discussions in the media. I give you a case. This is a 50-year-old geriatrician, a friend of mine. She developed relatively mild COVID infection 2 years ago, but has since developed ME and is in bed or in a sofa 20 hours a day and completely unable to work. Here I list some studies regarding COVID-19 consequences. Here is a 6-month follow-up of COVID patient in China that mainly had been hospitalized, so quite sick in the beginning. 6 months later, fatigue was very common. Another study from the USA, mainly outpatient, at 6 months, fatigue was in 30 patients, or 13% of the patient. And a new study from Iceland with a follow-up of 5 to 17 months found that the prevalence of long COVID was 7 to 8%, and severe symptoms persisted in 1%. Here you can see a list of common symptoms in long COVID. they are very similar to ME. Is it the same disease or a related disease? We'll find out later in this talk, or later in the symposium. And now we have guidelines regarding long COVID. There are more than 500 million known cases of COVID-19. So if 1% of COVID-19 patients will develop ME, that must indicate a serious healthcare issue. Vilborg Ása is a ME patient. As she wrote on social media just recently on the ME Awareness Day on the 12th of May. She said, despite the fact that the LA epidemic occurred 88 years ago, the pathogenesis of ME is still unknown and treatment options are limited. This can be attributed to the healthcare system global lack of interest up until now, when millions of patients are suffering from ME following COVID-19 infection. Of course, I'm happy there is finally some hope for a successful treatment. At the very least, it will finally be acknowledged that this is a serious disease and those who suffer require adequate support. Although there is now hope in the ME community that COVID-19 studies will lead to a better understanding and treatment, we have to remember that ME can be a dead serious disease. Mr. Sveinn Benediktsson died of consequences of ME last week. Although this is so sad, I hope you enjoy the rest of the symposium. Thank you.